Bismillahirrahmanirrahim. My lecture today is about the basal ganglia. In this part 1, I will discuss the anatomy of the basal ganglia and the unilateral basal ganglia lesions. Alhamdulillah, wassalatu wassalamu ala rasulullah wa ala alihi wa sahbihi wa sallam ajma'in. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأقربنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم آمين وأجمعين يا رب العالمين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. The term basal ganglia refers to group of structure found in the deep cerebral hemispheres, and it is included caudate, putamen, and globus pallidus. The caudate or globus pallidus, it is called also lentiform nucleus, and it is also with the substantia nigra and the subthalamic nuclei. And these structures belong to the extrapyramidal system. The caudate nucleus and the putamen or globus pallidus are located in the cerebrum, but the substantia nigra, it is located in the midbrain, and the subthalamic nucleus located in the diencephalon. Many disease entities may present as basal ganglia abnormalities. Magnetic resonance and CT scan to this extent allow the detection of basal ganglia lesions and injury. Here we have the lentiform nucleus. It is descriptive collective term of putamen. This is the putamen, and this is the globus pallidus, which divided by thin layer of white matter, the lateral medullary lamina. Lateral and medial medullary lamina. So this is the lentiform nucleus, and this is the caudate nucleus. This is the anterior part of the internal capsule. This is the geno of the internal capsule, posterior part of the internal capsule, and this is the thalamus. Again, this is the external capsule. This is the lentiform nucleus. Putamen, it is laterally. Globus pallidus, it is medially. Internal capsule anteriorly. Internal capsule posteriorly, and geno of the internal capsule. And this is the head of the caudate nucleus, and this is the thalamus. Again, this is the putamen, laterally pallidus, medially caudate nucleus, and thalamus. Again, this is the putamen, laterally globus pallidus, medially, and the caudate nucleus here. The blood supply to the basal ganglia, the arterial supply, it is from the lateral and medial lenticular striate arteries from the middle cerebral arteries, and the thalamus is supplied by perforating arteries from the posterior cerebral artery. Venous system drainage into the deep venous system, superior and inferior thalamostriate veins, which are drained to the basal vein of Rosenthal, and then drained to the internal cerebral vein to the vena gallien, to the confluence, and to the transverse sinus. Here, the caudate nucleus, as we said, and it is supplied by the lenticular-striate arteries, and here the lateral lenticular striate arteries supply the putamen, and the internal capsule it is supplied by the anterior choroidal artery, and the thalamus, as we said, it is supplied by perforator striate arteries branches from the posterior cerebral artery B1 segment. On the MRI image, the caudate and the lentiform nuclei and the thalami following the signal intensity of the cerebral cortex. They are slightly hyper intense as compared to the white matter on the T2 images. In adult, the globus pallidus is slightly hypo intense relative to the putamen as the result of deposition of iron increasing with age. The same refers to the substantia nigra, which also belong to the deep gray nuclei with the highest level of iron. Anterior limb of the internal capsule separate the caudate nucleus, caudate head from the lentiform nucleus, and the posterior limb of the internal capsule lies between the lentiform nucleus and the thalamus. The external capsule is seen on the lateral aspect of the putamen and separate it from the insular cortex. The caudate nucleus is situated adjacent to the lateral ventricular frontal horn. Unilateral lesions of the basal ganglia can be due to Rasmussen encephalitis, diabetes with hemicoria hemipalismus, or infarction or tumor. The dilated verco-Robin or perivascular spaces are frequently seen in the lentiform nuclei. They are located around the lenticulo-striate arteries, and this finding is more often observed unilaterally, and the signal intensity of these foci follows the cerebrospinal fluid in all of the MR sequences. Verco-Robin spaces are normal finding. Rasmussen encephalitis is a progressive disease of unknown etiology, probably related to viral infection and autoimmunological response. Seizures, cognitive decline, and hemiparesis are the most common clinical symptoms. MRI include unilateral cortical and subcortical atrophy. The most marked in the region of the insula with hypersignal intensity or atrophy of the ipsilateral head of the caudate nucleus and increased cortical with or without subcortical T2 and the flare signal intensity. Here, an example of patient with Rasmussen encephalitis, as we see here, we have patient with increased signal intensity in the internal capsule, in the caudate nuclei here, and the anterior part of the lentiform lentiform nucleus. And following patient, follow up the patient after 16 months, we see dilated of the frontal horn with atrophic changes of the caudate nucleus, but it still has hyper signal intensity, and also we have increased signal intensity in the lentiform nucleus, as we see here compared to the normal side, and with cortical atrophy of the left side. So this is Rasmussen encephalitis patient before at the at the time of onset and follow up with atrophic changes. Hemicoria hemipalismus, unilateral involvement movement in patient with diagnosed with diabetes and hyperglycemia. And this is one of the complications of the disease. And they are result from the metabolic disorder in the basal ganglia and tend to subside as soon the hyperglycemia is controlled. Imaging study, CT and MRI, shows unilateral involvement of the basal ganglia and may show various signal characteristics. The constant feature are involvement the putamen and the hyper intense signal intensity in T1 images. However, the chorioathetoid movement may be bilateral, and so are the basal ganglia lesion in these cases. Here, patient with CT scan. Here on the left side, we have hyper dense area in the caudate nucleus and the bottom and the lentiform nucleus, as we see here. In patient with newly diagnosed diabetes, associated patient has chorioathetoid movement on the right side. And the MRI signal in T1, we have hyper intense signal intensity in the left lentiform nucleus, as we see here, and little bit hyper intense signal in the caudate nucleus as compared to the right one. Here another patient with hyper signal intensity on the bottom end with hyperglycemia. Sorry. The caudate nucleus and the bottom end are fed by the perforator deriving from the anterior and middle cerebral artery. The globus pallidus receives blood supply from middle cerebral artery perforator and from the anterior choroidal artery. Obstruction of the lenticulostriatal arteries or other perforator leads to selective ischemia of the caudate and lentiform nucleus, and usually unilaterally. The signal characteristics is typical of an ischemic focus with early diffusion restriction followed by T2/flare hyperintensity and T1 hypointensity. In this patient with Marfan disease, we have increased signal intensity in the T2 and with restriction, with diffusion, with restriction, and with ADC map, hypointense due to infarction in the caudate and lentiform nuclei. Thank you for listening and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.